Good morning, dear students. In today's session, we will be discussing about the second type of lymphoma, that is non-Hodgkin's lymphoma. So, in last day's class, we have seen regarding lymphoma, and there are two types, that is Hodgkin's disease and non-Hodgkin's disease. And we have seen that in Hodgkin's disease, there is a characteristic cell appearance, that is Reed-Steinberg cell, and there are different types of staging and also manifestations, management, everything we have seen. In today's session, we will be discussing about non-Hodgkin's disease, and this is also a neoplastic transformation of lymphatic cell, and it can be from B or T cell lineages. And non-Hodgkin's lymphoma causes the accumulation of neoplastic cells in both the lymph nodes as well as more often diffusely in extra lymphatic organs and the bloodstream. So this is very important difference between non-Hodgkin's disease and Hodgkin's disease. Hodgkin's disease, it was primarily seen in lymphatic organs, and it is slowly spreading to extra lymphatic organs. But when you're talking about non-Hodgkin's disease, it will be seen maybe during the diagnosis itself. During the diagnosis time itself, you can see the finding of the presence of abnormal cells in extra lymphatic organs, or the masses can be felt in different areas along with lymph nodes. So, a diffuse pattern spread can be seen in non-Hodgkin's disease. And one more important difference between these two are this non-Hodgkin's disease, absence of Reed-Steinberg cell. There is no Reed-Steinberg cell, which is a characteristic finding which can be seen in the Hodgkin's disease. Next, we can see regarding this some of the risk factors. One thing you have to remember that it is more amount of incidence occurs in more than 60 years. So that's why we cannot uh, explain that among children it is very common, or it is not common among children. And some diseases like infections and some diseases are having more risk of getting this non-Hodgkin's disease, like infections like HIV, Epstein-Barr virus, hepatitis C virus, then H. pylori infections. So along with these all infections, we can expect some amount of non-Hodgkin's disease occurrence. And other diseases include rheumatoid arthritis, SLE, Jorgen's syndrome, mixed cryoglobulinemia, inflammatory bowel disease, and inherited immune defects. So these are some of the diseases and infections which give some increased risk for getting non-Hodgkin's disease, and theory is still under study. Some symptoms of non-Hodgkin's disease, as we already discussed, that there is a diffuse pattern of spread, and this extra lymphatic uh, spread is more in non-Hodgkin's disease. This the first symptom is mass effect. So mass can be felt, mass can be found in different body parts, like lymphadenopathy can be seen, and occipital, posterior auricular, preauricular, mandibular, submental, cervical, supra and infraclavicular, Waldeur's ring, axillary inguinal, popliteal, hepatosplenomegaly, mediastinal, abdominal, pelvic, testicular, and CNS masses can be felt in non-Hodgkin's disease. So, in different areas, we can expect the mass effect, maybe in single or in more area, we can expect the mass. That is known as the mass effect. The other symptoms include hematologic, that is anemia, thrombocytopenia, lymphocytosis. Then constitutional symptoms, we name it as A and B. So B with the symptoms, that symptoms include fatigue, anorexia, pruritus. Then paraneoplastic syndromes, That means the person will have an increased susceptibility of getting infections because of this immune functioning cells are abnormal or it is decreased function. So the person will be getting more chance of getting repeated infections and other complications. So these all together we name as paraneoplastic syndromes. Next, we can discuss about the physical examination of a patient for this non-Hodgkin's lymphoma. So, evaluate for hepatosplenomegaly, then presence of effusion that can be present. Then evidence of neuropathy can be there because of the compression effect of this mass. Then the signs of obstruction can be seen in the extremity, edema can be seen, superior vena cava syndrome because of the partial or complete obstruction of the superior vena cava. Then spinal cord compression can be seen, hollow viscera dysfunction can be seen. So these are some of the signs of obstruction which can be evaluated under the physical examination. Next we have to evaluate for lymph node chains including submental, subclavicular, supraclavicular, infraclavicular, then epitrochlear, then iliac, femoral and popliteal nodes. So different lymph nodes we have to examine for the enlargement of lymph glands. So we have to palpate the different areas of lymph nodes for the mass palpation or for the lymphadenopathy. Then lymph nodes examination for size, multiplicity, the presence of number of lymph nodes, and the consistency if there is any tenderness. So these all things we have to examine in the lymph nodes. So these are the appearance of swollen lymph nodes and the normal lymph node. Next we have to examine the tonsils and the oropharynx. So the Walde's ring involvement mandates complete evaluation of the nasopharynx, oropharynx and the hypopharynx by endoscopy. So whether it is involved, Walde's ring is involved, that can be confirmed by endoscopy and evaluation of the nasopharynx, oropharynx, hypopharynx and the endoscopical examination can be done. Next is the investigations. So hematological test, basic test we will be doing, that is FBZ, peripheral smear, electrolytes, urea creatinine, that is AST, ALT, ALP, bilirubin, calcium, LDH, ESR, albumin, serum, protein electrophoresis, then hepatitis C, B and HIV infections. This all test will be, complete blood count also will be done for basic examination for non-Hodgkin's disease. And diagnostically, abnormal circulating lymphoid cells or lymphocytosis can be found in the hematological test, and acute phase reactant test can be done and liver function test can be done. And other tests which include renal function test, serum uric acid, hypercalcemia, serum lactate dehydrogenase, then serum immunoglobulins. Then biopsy can be done as an investigation like peripheral node biopsy, inguinal lymph node biopsy, bone marrow biopsy, endoscopic gastric biopsy and true-cut biopsy of retroperitoneal and mesenteric masses. So depending upon the presence of nodal enlargement or the mass involvement, we can take the site for biopsy. Next is a mediastinoscopy or limited thoracotomy will be done. Laparotomy, laparoscopy, endoscopic gastroscopy. These all investigations are done based on the presence of mass on these all areas. Then evaluation of the chest can be done like chest radiography, CT scan, thoracocentesis and pleural biopsy. So these are the different investigations which we do for diagnosing non-Hodgkin's disease, and these many investigations are required because we already discussed that there is diffuse spread of this disease comparing to Hodgkin's disease. So we cannot expect where and all we can find the masses. So that is the reason why we do a complete examination of the patient in different body parts for the mass presence and the involvement of non-Hodgkin's disease. Evaluation of the abdomen and retroperitoneum can be done by CT scan, bipedal lymphangiography, then abdominal ultrasonography. Then evaluation of the gastrointestinal tract by barium enema, endoscopic examination of the GIT and biopsy of accessible abnormality. If anything is found abnormally like mass in the GIT, we will be doing like biopsy can be taken. Next is the evaluation of the CNS. So we do lumbar puncture and the spinal fluid examination will be done to find the lymphocyte, abnormal lymphocyte. Then CT and MRI also can be done to find the mass in the brain and other area. Next is a nuclear scan. Positron emission tomography scan will be done and Gallium scan will be done. This is to find the spread or the diffuse pattern spread of this disease. So this non-Hodgkin's disease will be seen or the migration from one area to another. This is very fast and that should be done, that the positron emission tomography will be helping to diagnose the pattern of spread in the person with non-Hodgkin's disease. So this is the finding which can be seen in the PET scan. So much body parts are involved, and this is the spread pattern which can be expected in the non-Hodgkin's disease. When we are comparing with the Hodgkin's disease, this is very diffusely spread. Regarding the treatment of non-Hodgkin's disease, usually surgery can be done if the mass involvement is not that bulky and some areas can be identified. The surgical option, surgical management is done. Radiation is done in the areas of involved. Chemotherapy and combined chemotherapy with radiation and surgery also can be done. And in some patient we will be doing autologous stem cell transport. So the same the individual stem cells will be treated and it will be transported and it will be given back to the patient. So that is the autologous stem cell transport as a management for non-Hodgkin disease. If the person is not responding properly to the chemo, radiation and other options. So this is about the treatment. So hope you all understood the topic and you had to understand the differences between Hodgkin's and non-Hodgkin's disease also. And thank you for your kind listening. Thank you very much.